So what I was hoping to do, and I just put a couple of slides together to tell you a little bit about where I come from about my center and the research we do in my center, and talk a little bit about some of our global projects and collaborations. So I hope that's okay with you. So, I'm a professor at School of Nursing, a School of Public Health. I am also director of the center. It's called Center for Healthcare Delivery Research and Innovation. So, I have a pleasure of working with a talented group of individuals. So, this is I put a website here. I was going to click on it, but I don't want to mess up with the with the screen. So I'll talk. I said a little bit about our center, about our international collaborations, and I'll give you some examples of the research, hoping maybe we can find ways of collaborating and doing work together. By the way, I am originally from Armenia, so I'm Armenian, but I live in New York for about 15 years now. So doing global research has always been part of my identity. So, what is our center? So, our center's goal is to really do a strong nursing research and also create opportunities for students to really network, build their program of research, get to know each other, have help, because I really believe you cannot do good research by yourself. It's good to help, especially the next generation, to have support resources they need to do the research. So this is my building where my office is. You know, and it's a nice building. It's one of the new buildings we got a few years ago. So in the center, who we have professors, we have full-time staff, five staff, we have PhD students, we have postdoctoral research trainees. These are people who already have a PhD and they're coming to study with us for 2 years to do a research. And we also have many, many, many master's level research assistants. We get a lot from the public health. On the website, I was going to show you who the members of my team are. So if you have a free time and that link works, please click on it and see. And I think I have Apirati's name listed there as well as one of our visiting scholars. But while we have an internal team who does the research, we also have an external board. I put their pictures here. This is our external board who kind of advises us, gives us suggestion how to grow the center and conduct the work. So what are some of our research projects about? So what we do mostly is about producing research that strengthens healthcare delivery, both in the US and internationally. And I put some themes here. So mostly we focus on optimizing healthcare professionals' roles, registered nurses, healthcare teams, particularly nurse practitioners. We do a lot of research about nurse practitioners because nurse practitioners are the fastest growing workforce in the United States, and they are increasingly delivering primary care. So my team is one of the first teams in the country to really systematically study nurse practitioner workforce. One of the issues in the US that is the health disparities are a big issue. So certain groups of Americans get good care versus the others, particularly racial and ethnic minority communities who live in a poor area. So a lot of our research is about how we can effectively utilize nurse practitioner to reduce health disparities in underserved areas. We do a lot of research on dementia because, we know that dementia is a chronic condition. We need to learn how to better manage it when people get that dementia. And we do a lot of chronic disease management research. And we also have a lot of research on healthcare teams. I'm going to walk you through a couple of studies that we do very briefly. So if you have more questions, I'll be happy to ask. But so just give you an idea. So for example, this is one of our large projects. It's funded by National Institute of Nursing Research. It's a US government, federally funded. So what we do here, we try to see where nurse practitioner clinics are because very often these nurse practitioners practice in the communities that are low income, they're rural, they don't have enough healthcare providers. So we're trying to see if how these neighborhoods and clinics deliver better care to patients, because we're hoping to have some evidence that says you need to invest in these communities to improve patient care, and also you need to invest in clinics where nurse practitioners work, because sometimes nurse practitioners work in clinics that don't have enough resources, structures to deliver best care. So this is an ongoing large study. So we're working on it right now. We for a part of this study, we collected survey data for about 900 nurse practitioners, and we have a patient data for about 2 million patients. So we're going to use those data to do our aim, to achieve our aims. We have another large R01 study. Again, this is funded by the U.S. government. It's National Institute of Aging. NIA is a National Institute of Aging. It's about, again, how to effectively use nurse practitioners to improve care for patients living with dementia in various communities. In this study, we're also surveying nurse practitioners. We're doing qualitative interviews, and we're getting patient data. We have another project from NIA. We were trying to understand the social networks. It's an interesting concept. Is mostly how MP teams communicate, share advice, trust, support, problem solving. These are our social networks when they deliver care to patients with dementia. We know that delivering care to patients with dementia is not easy. This is a complicated, long-term care delivery, and we're trying to see who MPs ask for help, who they go to when there's issue comes up, so we can really support nurse practitioners to deliver care. And then we're merging this social network data with patient outcomes, saying that if MPs work in teams where they communicate well, share advice, trust, support, our patient outcomes better. So that project is also ongoing. And we have another federally funded R01 that looks at the clinics. This has 23 primary care clinics. We're trying to understand who works in these clinics, because when we talk about teams, every clinic is different. And we don't have any good evidence to go to clinics and say, you need to build a team and you need to hire these people, because every clinic is different. So our job is to see what clinics are better. So we ask who works in the clinic, and then we go into electronic health record data to pull out patient data from that clinic to see if that clinic patient outcomes are better, to say your team is good because your outcomes are better. So we're doing this study in 2 states, in New York and Pennsylvania, and in 23 clinics. So that's also one of our ongoing studies. We have another study. What we are noticing is that a lot of patients with dementia do not go to clinics anymore because they don't want to leave home. It's very challenging to go and be in an unfamiliar environment. So what we were noticing, a lot of nurse practitioners go patients home to deliver care. So this is called home-based primary care. So we are studying to see, and you know how difficult it is to go into every home is different, right? So it's not a controlled environment. It's not a clinic. So we're trying to understand how this home-based care delivery affects nurse practitioners and eventually patient care. So these are some of the projects that we have ongoing in our team. What we also have, and I'll be happy to answer any questions about these studies, if you have any questions. The other interesting thing we have in the U.S. in our center is called T32. It's again U.S. government-funded project where the goal is to train nurse researchers. So it gives stipend, scholarship, tuition for PhD students and for postdoctoral fellows. So every year I have 3 PhD students and 4 postdoctoral fellows that government pays their tuition to work with me. So we have this project also ongoing that allows us to train a lot of PhD and postdoctoral fellows. So those are some of the international national and local projects we do. But one of the things we also do is we work with 10 plus countries. We try to have various collaborations in Canada, United Kingdom, Ireland, Germany, Switzerland, Greece, Armenia, Thailand, and Japan. So we're hoping to create collaborations and partner together to study various nursing workforce issues. So I'll tell you a little bit about our project in Greece. So the project in Greece was about advancing nursing workforce in Armenia and Greece as advocates for care of displaced population. So, Greece and Armenia have a lot of refugees. Geographically, they're located in a parts of the world that, Greece gets a lot of refugees before they go to a northern Europe. And Greece, it puts a lot of pressure on the healthcare system. The same in Armenia. More than 3% of Armenia's population were refugees, and Armenia is a very small country. So what we were made an argument in this project, and we got funding from the president's office, was that nurses historically are always the first point in contact with the refugees, with the migrants, because you want to make sure that, let's say, if a refugee breaks the leg in Greece, they go to emergency room, right? But you need healthcare to prevent that. You need their vaccinations, pregnant women, prenatal care, elderly with their chronic disease management, asthma, and hypertension. So nurses are always in this first point of contact to care of displaced. So we wanted to make sure that we bring people together to discuss how to help nurses to deliver better care for these refugees. One, to help them have better healthcare, and then two, kind of reduce the issue on the healthcare system. Because, when 3% of your population are already refugees, that puts a big burden on the overall healthcare system. So the goal was to kind of organize two symposiums, one in online we did in November, and then we had a 2-day in-person event in Greece in April, and we just had another one in December. I didn't put it there, December 2025. So we had 3 events, and each time we have about 200 people attending our seminar. So we had speakers from the United Nations, from Medicine Without Borders, from various organizations. And this picture is from Greece. So we went to Greece to really come together to discuss how to help healthcare systems to better use nurse practitioners to deliver care to displaced populations. And those are my students from Colombia. And Rika is from Japan. Helen, she's American. So all 4 of them came to Greece with us to really help with our projects. So the projects are ongoing. We have another project pending. We're hoping to get funding, trying to understand nursing workforce in the hospitals. One of the biggest issues in Greece is that hospitals cannot hire nurses. They're not nurses to hire. So they built new hospitals, but they close the units because they don't have enough nurses to operate the units. So a lot of units on the hospitals are shut down. So one of the reasons is that young people don't want to be nurses because the work is hard, salaries are not good, it's not very reputable. So we're trying to change the perception of the public to see if we can really increase the value of nursing as a good career path for the young people. And then we're also trying to work with the hospital leadership to really create a better environment for nurses to work, because there's a big foundation in Greece that builds hospitals. But the issue is going to be that you build a building, but if you don't have nurses, you don't have a hospital. So that's a project that's hopefully, we're trying to conduct in Greece and Armenia. I put up Iradi's picture here because I had my team and I had a pleasure of, yes, hosting Apirati in New York, and my team learned so much from working with her, and we're hoping to continue our collaborations and yeah, I like that picture. And we're going to hopefully have some collaborations and with other colleagues from Thailand, and we can continue our work together. So I mentioned that mostly we do nurse practitioner research, right? I wanted to show you why we do nurse practitioner and talk about one of the tools that we developed that's being used a lot. So I know, Thailand has nurse practitioner role. I know it's newer than in the US. I've worked with Abhi on a couple of papers about this. So in the US, nurse practitioner role is very old. It's from 1965. And what MPs can do in the US is they can diagnose, they can treat, they can prescribe medication, they can manage, they can coordinate. So they can provide full primary care to patients based on their education and training. But one thing I was noticing, yeah, ask it. State. So, so in the U.S., are you asking about U.S. or in internationally? To be honest, no, you're right. Yeah, yeah. Let's
So
have a conversation.
okay, we have some students from China too, so you
Yeah.
can share how NP in your country look like. But I will tell about in Thailand.
Yeah.
Even though I'm not real from the NP, I mean from the community area, but I did research about this topic. So and uh, from the issue that Dr. Kateria she raised about that NP in Thailand, we can do quite similar, but not like 100% like in US. So NP in Thailand need uh, certificate for 4 months, training, like a 4 month, and another track is uh, finish a master degree
Okay.
in community NP. So this is the in Thailand. But for the scope of practice, it's quite similar, but I'm not sure in the detail.
Okay.
For example, what kind of medicine?
Okay.
We quite strict and limit just only some medicine.
Okay.
Like a primary treatment, something like
Yeah.
that.
In the US, and I had that slide also, but I removed because I didn't want to talk a lot about US. Every state has different regulations in the US as well. So in 28 states, MPs can do everything. No, like all medication. There are some controlled substances that they might require some approval for an MPs to prescribe, but in 28 states, MPs can do everything in a primary care. In other states, some state laws require MPs to have a collaboration with physician, which basically is a piece of paper that says, "Oh, I work with this MP." And in some states like Texas, California, they're called restricted scope of practice, where there has to be paperwork that says, "Oh, MPs have to be supervised by a physician." But in the other 28 states, MPs can do pretty much everything. Yeah, but you're also right, right? The education is very different in the US. To become an MP, you have about 2 years, up between 2 to 3 years, to specifically become an MP. And a lot of people go to school directly to become an MP. So, but on the other hand, like in the US, it's been for a long time, right? Things will change. I think one of the things I was learning about Japan is that they have a lot of rural areas, which I think is very similar probably in Thailand as well, like where they don't have any other primary care provider. So they're slowly trying to expand nurse practitioner scope so they can have more responsibilities, you know. But and Thailand has been like what, 2000, right? The role was established. It's 25 years ago. Yeah. Yeah. Yeah.
Actually, I didn't work at the hospital before, but for my how to say understanding, maybe not as so much scope as in Thailand and in America. For China, maybe every nurses should follow the the doctor's prescription. So cannot work back there or yeah.
Mm.
So,
Yeah. Mm.
yeah.
Doctor.
Must follow the doctors, yeah,
Yeah.
in China like this.
Yeah.
Cannot, diagnose, no, use the medicine cannot, yeah. But just related some nursing care as like this in China.
Yeah, it's so it varies. I had again, I said I had another slide that showed what countries have the nurse practitioner role. So you're right. It's really varies from country to country. Same in Europe, for example, in Netherlands, MP role is very well developed, but in France or Germany, not. So it varies from even within Europe, the issues. But the reason, but a lot of countries are trying to change because people are getting older. And in most countries, right? We know that most countries people are getting living longer, and chronic diseases are getting higher, and we don't have enough primary care providers, so we need to have different way of delivering care to patients. And it seems that nurse practitioner role is growing to be that category to really help people to get care. So yeah, even in the US, a lot of things are still changing with it. But a lot of students want to become MPs now. A lot of students. And I don't know. I think I didn't mention is that I think it's like a number 2 fastest growing job among all professions. All engineers, architects, builder. MPs are number 2. Eh, Yeah. So which means there's interest among students to become nurse practitioners, and there's interest in the healthcare system to hire them, right? If there are no jobs, nobody wants to become an MP. So there are jobs, and it's a very well paid job. People make, very well paid salaries by becoming an MP, so they can have a good life as well. So, yeah. So that's the role of MPs. But one thing, when I started studying MP workforce many, many years ago, I was noticing that because my dissertation was about registered nurses. So I was studying registered nurses in hospitals. But what I was noticing is that MP workforce was growing, but people were not paying attention to it. And I'm like, this is very interesting. It's a new role, it's growing, and nobody is paying attention to it. So I started writing about it. I said, I have a paper, 2011, I think, like 15. I said, we need to watch this workforce. And because what I was noticing is that when the workforce starts growing very fast, people don't know about them. Like very often, nurse practitioners were being hired, but they're being used as registered nurses because clinics didn't know what nurse practitioners are. So I started writing papers about that why would you pay someone a high MP salary, but use them as a registered nurse just because you don't know what MP education is, MP scope of practice is. So I wrote a grant to the US government. This was my first big grant. I was assistant professor. I knew nothing what I was doing. So I said, let me try it. And I proposed the idea of saying, can we understand why in some clinics MPs are really used well, deliver care? In other clinics, their role is completely different. So I proposed to develop a tool called Nurse Practitioner Primary Care Organizational Climate Questionnaire to understand practice environment of MPs from one clinic to another. And I wrote a grant. I didn't even know how to write a grant. And when in the US, when you submit a grant, you get a score. I was so naive that I didn't even know what that score meant. It's a good score, it's a bad score because I've never done it. Reviewers liked the idea. So the project got funded, and I got to develop this tool that we call MPPCOCQ. So what is the tool? Tool has 29 items that ask nurse practitioners to evaluate if certain characteristics are present in their work setting on a 4-point scale from strongly agree to strongly disagree. So it measures MP physician relations, MP administration relations, independent practice and support, and professional visibility. So when originally it's 29 items, we just got a paper accepted that where we cut from 29 to 17 items because we're noticing that I developed this tool in 2011 and it's been 15 years now, right? It's time, things have changed. So our new paper where we cut 12 items just accepted for publication in nursing research. So we're going to start using a 17 item instead of 29 items. So I developed it for our own research purposes. But then people wanted to use it. So right now, the tool is being used across the US and in these countries. So every week we get requests from researchers in, South Korea, Canada, Japan, Switzerland, Saudi Arabia, Philippines, Taiwan, France, Germany, Lithuania, Thailand, Nepal, Australia, Netherlands. These are the countries that have used our tool to study nurse practitioner workforce and published a couple of papers that I was looking. So what do we do with the tool? So we survey nurse practitioners, and for example, we can understand if MPs who work in a good practice environment they're more likely have a higher job satisfaction and stay in their job, don't leave their jobs. The retention is stronger. So these are just titles of a couple of publications of ours. So if you are interested, I'm happy to share the papers as well. Then we wanted to see, first we did in one state. It was Massachusetts. Now we did in the 6 states. We said, okay, if it works in one state, does it work in the 6 states? So we did that. And then we said, okay, fine. We found in these studies that if nurse practitioners work in good environments, then their outcomes are better. They're more likely to have a high job satisfaction, low burnout, and do not leave their job. But then we said, okay, if you work in a good environment, is it impacting your patient care as well? So we surveyed nurse practitioners. We linked the MP survey to a patient outcome data. And we show that if MPs practice in good environments, then their outcome, their patient quality of care is better. And we had another study also where we showed that MP burnout, if MPs are less burnout, their patients are more likely not to go to emergency rooms. So these are just titles of the publications, and then my students have been using the data that has been produced from our studies to study different, and you see Min's name here. She's from Thailand, right? You recognize that Thai name? So, and Mint was very much interested in community health centers which deliver care in underserved areas. Yeah. Yeah. She's amazing. And I loved working with her. She's an incredible, I'm gonna text her that I've been talking too much about her. Yeah, she's incredible. So if you have a chance to collaborate with her, she's a great colleague, and Api already knows her. Yeah. Okay. So yeah, you should. You should. Yeah. I don't. I'll send her a message, but she was fantastic. I really loved working with her, and we're in touch still, even if she left me, finished her studies with me. I know about her career paths, and she always reaches out if she needs something or something comes up, you know. Um, um, so that's what our projects are. And I think I mentioned that we also did a lot about nurse practitioners in dementia care. So we wrote this paper a few years ago where we said nurse practitioner workforce is a solution for the aging population with dementia. And as you can see, the editorial was written on our paper, and they agreed with us that nurse practitioners and dementia are a perfect fit. So my team studies are now focused on a lot about can we effectively use nurse practitioners to deliver better care to patients with dementia. So those are some of the work that my team and I do. And of course, my trainees, my PhD students and postdoctoral fellows are studying different things like substance use disorders. How can MPs help with the substance use disorder in rural areas? Deliver care to patients with multiple chronic conditions, serious mental illness, people who don't speak English and have disabilities. So as I mentioned to you that we did a lot of work on MP workforce, right? We had many projects. So my team and I said, okay, what's next? So we wrote a small grant from the US government again, and we got funded to say, what should we study next by 2030? Because what are some of the questions that are left unanswered? And I invited people from, from US, Canada, Israel, Germany, and this is us at Columbia to kind of discuss what are the next steps about studying nursing workforce. And with these experts, we came up with a couple of questions that next generations can study. That what are some of the unique attributes of NP care models? Why is NP care good? What it makes it unique? How we can better use NPs and integrate them in different settings, and how can we actually translate the evidence to really help MPs to have a full practice authority, and how we can reduce cost, improve quality, and improve access. So we're still trying to grow the research, and these are some of the projects we're doing. One thing I want to emphasize, I don't do this alone. I am very, very lucky to work with a brilliant, hardworking, talented team of people. I have fantastic mentees, mentors, and these are some of the founders who gave us resources to be able to do the work, because, as you all know, we need resources to do research. And my center sends a newsletter. So if you want to sign up, here's a QR code my team gave me. So you can scan and sign up, and you can get updates. And, and if there are any things, reach out. That's all I have planned for you, just to kind of, I hope this is what you're expecting. I'll be happy to answer any questions.
The
Sounds good?
first question before next question.
Yeah, please, let's have the conversation.
Introduce you.
Okay, so a new, she's
Yeah.
colleagues, our
Hi.
colleague.
Good morning.
Good morning.
I'm Lavita Kielkom. You can
Lavita?
yes.
Okay, nice meeting you, Lavita.
Yeah. I'm from Faculty of Nursing or OBGYN department.
Okay,
Okay, nice to see you
same.
today. Yeah.
It's very nice meeting you, Lavita.
Yeah.
Thank you so much for coming. Okay.
She graduated from UK.
Okay. So
So
when UK? Okay. I was I was a visiting professor at King's College in London, a little bit, right before COVID.
Okay, so can you tell us more about the education of NP in the US? Because as we know, that is quite different from other countries, including Thailand.
Okay.
So
Yeah, of course. So, as I think I mentioned briefly, was that nurse practitioner role was established in the US in 1965. And the reason was that what they're noticing is that a lot of children, a lot of people who live in underserved and rural areas were not having enough primary care. So NP role was developed in 65. But imagine from 65 till today, it's changed a lot, right? So, so MPs, most part of this, 50 years, are, or 60, it's 60. Oh my God, my math is not good. So, a lot of MPs were still practicing at a master's level. So you have to go be a registered nurse. For 4 years, you study, you get a bachelor, and then you go to the school about 2 years specifically to become a nurse practitioner and get a master's degree. So most of the nurse practitioners have been studied at a master's level specifically. In the past 15 years, there was new degree that emerged in the United States. It's called Doctor of Nursing Practice, DNP. So it's a doctorate degree. So all the large nursing organizations are telling that now if you want to be an MP, you should have a DNP, which means it's another year and a half, 2 years, 18 months education. It varies from school to school, but it's about 18 months. So now a lot of schools eliminated a master's program. So now you get a bachelor's and then you go a 3-year DNP. So there's no master's degree in between. So that's a new trend. Then there are some arguments that, physicians do residencies, MPs do not do residencies. Some schools some nursing schools say, you know what, 3 years of education is enough. They don't have to go and do residencies. Some schools offer residencies, couple of months of like 4 months, 5 months. But the issue is that they have to find hospitals for a residency or fellowships. But I would say typically the nursing NP education nowadays is bachelor's degree, about 3 years of DNP, and NP, and then NPs are ready for practice. So that's very, but again, US is very large, right? Like every school and state have their differences, but I think that's more typically happening right now. But you still have a lot of NPs who just have a master's degree. Mm.
So I would like to ask one question is about the DNP educations. So they have like subcategory like midwifery or any to continue or during the 3 year period, do they have to select or be specific in what they would like to be specialized? Yeah.
So that's a very good question because in the US, you have a midwiferys that are different than NPs. There's also CRNA, certified nurse anesthetist, that are different type of advanced practice nurses. So yes, so for example, if you want to have a DNP in midwifery, it's a DNP in CRNA and DNP in NP. There's no specific specialization like family, pediatric. But some, for example, in my school, we had a pediatric program, we had a family MP program. So yeah, so you have to decide what type of are you going to be a CRNA, you're going to be a nurse midwife, you're going to be an MP, and within MP, are you going to be most like pediatric MP, psych MP, mental health MP, but most MPs are doing general family medicine type of broad primary care MPs, so something like that.
Also require like working experience.
In the past, they did, but they
Yeah.
don't do it anymore. You can directly go and become an MP.
Oh,
Yeah, and that also is raising a lot of issues because a lot of physicians are criticizing that before someone became an MP, they were a nurse for many, many years. Now you have students who just go from nursing school to an MP, DMP, and some criticism is that, oh, they might not have enough experience to work, but it's not a requirement anymore. Yeah. Please.
They have are there any test for license to be named before that?
Yes,
Okay.
yes. Their license they have to state for the board exam. They have to do, yes, absolutely. Yeah. Because, and that's why a lot of the nursing schools say that, look, we educate them, they pass the exams, so they're ready for practice. Yeah. Yeah.
one more question, please. Yeah. I'm just thinking is about foreigners who want to continue DNP. So is there any like special requirement for like the license? They need to
Yes.
get like nursing license
Yes,
before
you
practice.
you have to have a U.S. nursing license. Yes.
Okay.
I think one of the things that we don't usually get a lot of international students in those programs is one, it's very expensive. Because, for example, because one of the criticism about DMP is that also a lot of nurses are criticizing, saying, well, now I pay a master's tuition and now I have to pay a DMP tuition. It's expensive. And that's why we often get international students in the PhD program because we pay. PhD is we have a stipend, but DMP's program is it's about 120,000 US dollars for the program or more. That's a lot of money. But you have to have a nursing license before you go actually have a DMP program. Yeah. For the PhD, you have to be eligible for a license. You don't have to have a license for a PhD. But for DMP, you have to have a license because you're going to go to clinicals in the hospitals and things. You have to have a license. Yeah. And it's extremely expensive. Okay.
So, can you tell us about how the workplace for the NP in US? So I would tell you that in Thailand, we NP work in not only primary care unit, but also in community hospitals.
Yeah.
But I'm not sure for the in US
They do.
how they look like.
So even that's a good question, like where MPs work. So before, so even though most MPs are trained, do deliver primary care, a lot of MPs work in acute care. And I think one of the criticisms, like in cardio practices, how or in hospitals, one of the criticism is that hospitals pay more. Like the same thing happened with the physicians in the US, right? One of the reasons we don't have a lot of primary care physicians is because if you become a neurologist, you become specialist, you become a, dermatologist, you become OBGYN, you make more money than, or if your hospital do a surgeries, you make more money than if you are a primary care physician. That's why a lot of young people do not choose primary care specialties in medicine. The same issue is gonna happening in nursing. So a lot of MPs are now choosing to work in hospitals, in acute care units, in emergency rooms. But still, majority, I think about half are still in primary care. 50, 60% are in primary care, but the other 40% are in acute care settings. Yeah. And they're also saying that sometimes primary care is very complicated, right? You can get any type of patient, while in acute care, you're very specialized. You know, this is a one type of a patient you're going to see most of the time. So a lot of surgical units. I work with the colleagues in University of Michigan, and we have a project about MPs in surgical units. And we're seeing that a lot of surgical centers, where they do surgeries, they're hiring MPs.
They open their own clinic.
Yes.
Oh.
So one of my center team members, Monica, and I think you met Monica. So her name is Monica O'Reilly Jacob. Her area is studying MP-owned practices. So a lot of MPs in the US now are opening their own practices, specifically like even that home-based clinics. So MP just decide to open a whole clinic that goes to the homes. In this way, you don't have to have an office. You don't have to have a. It's easier. So a lot of MPs are, especially in the states that have those full scope of practice, they own their own practices. It's growing industry. And Monica on my team specifically studies MP owned practices. Yeah.
Once patients they go to NP
Yeah.
practice. How I mean when they pay for the fee
Okay.
something, can the government, I mean the insurance
Paid.
pay,
Yeah,
right? Mhm.
So one of the issues, so when MP patient goes and sees a MP, insurance pays. It's the same way as it, but there's one difference. So Medicare, which is a US federal insurance for older people, 65 and older, pays 85% of the physician fee. For example, let's say if I go see you as an MP, government says the visit is $85. If I go do for the same thing I see a physician, the government says it's $100. So they pay more the physician than MPs for the visit. Then what happens in the clinics, patient comes, sees the MP, but in the patient record, clinic puts that a patient saw a physician so they can get more money. So it's called incident to billing. When I heard about it for the first time, I thought it was illegal. I'm like, what do you mean? If you see an MP, record should show you're seeing an MP. No, it's called incident to billing. So sometimes in the data, you can see a physician who saw 200 patients in one day. Nobody can see a 200 patients in one day, right? So it means a lot of MPs work in that clinic. MP saw the patient, but the physician billed so they can get 15% more money. I know. So that's one of the biggest issues about billing in the US as well. Yeah. Yeah. So a lot of things, even though MP role has been around for a long time, there's still a lot of issues in the US as well. A lot of like this is an issue. Why would you because imagine this is also like increasing healthcare cost, right? If actual care was 85%, then let's pay 85%, rather than use this loophole to pay more because physician can bill for it. Yeah. So there are a lot of interesting things happening. So that's what my team and I are trying to slowly study. And, I fundamentally believe that as a healthcare system, we have to learn how to deliver better care to people in primary care because nobody wants to go to a hospital. it's not a good place. It's not a good place for clinicians. That, we see the burnout and turnover. It's not safe. We see the medical errors. We see infections. So if we can find a better way to deliver care, people in primary care, to prevent people from going to the hospital, I think that's the best investment. So, please.
Is about like what differences between public and private hospital setting. Because it just just shares get the sense of what different, because in Thailand we have too many different healthcare coverage, but if someone in the middle class, he can buy their own private healthcare coverage. They prefer to go to the private hospital because it's more convenient and like it's less waiting time. But if compared to you in the US, it's about like NP providing care in the public, or how they get paid different between those two settings.
You have universal health coverage, right, in Thailand? We don't. In the US, we don't. We don't have a universal health coverage, so it really doesn't matter, right? You have your insurance, you can go wherever you want to go. If the clinic takes your insurance, because there are a lot of clinics that don't take your insurance. For example, so we have this insurance called Medicaid. Usually people who have low income, so they are insured under the Medicaid. Have disabilities, they don't work, a lot of clinics don't take that insurance. So even though there are public or private clinics around you, the clinic does not take the insurance. So you have the insurance, but you cannot have access to healthcare. But then there are different clinics that they're called federally qualified health centers that are run by the government. And sometimes this insurance, Medicaid, assigns you. You say you only can go here because that's what we pay. So it's a very complicated system in the US because we have federal insurance, we have state insurance. For Medicare, it's federal. So every American who is 65 and older gets Medicare. Medicaid is state specific. Every state decides you're eligible for Medicaid or not. And then we have private insurance, which my employer, like, let's say I have insurance from my job. My job gives me insurance. It's a private insurance. So then I have to see what clinic takes my insurance. If clinics don't take my insurance, I cannot go there because it's going to cost me a lot of money. So it's mostly that type of a system, which is extremely complicated. Make sense? Yeah, you got it. Anytime.
Because of you did many research about NP and outcomes. Can you tell us the results of the outcome and how NP value for the population?
Sure. So what we are seeing is that MPs increase access to care. So there are a lot of studies, including my teams, that shows that when you have MP in the neighborhood, access to care is better because people have a place to go to get care. And these are usually in racial and ethnic minority communities. A lot of Black and Hispanic people live. These are usually rural villages. You can see rural areas that MPs are improving access. We also see that MP improve quality of care, prevents acute care use. Where we see if MP delivers the care, we see that patients do not go to emergency rooms or hospitals because there are type of emergency rooms that are called preventable. Because we know, like if you show up there in an emergency room, a lot of it's preventable. Because one thing in the US is that emergency room is free. Government, if you have emergency, you can go. But but it costs a lot of money for the government to pay or the insurance companies to pay for the emergency room because you don't have to go for to an emergency room for simple things that can be managed in a primary care. So we see that MPUs also reduces emergency visits. We see that MP care also saves money because emergency rooms are expensive. So yeah, so these are the outcomes that we have seen. Mostly that it improves access, reduces cost, and reduces acute care use. And one of my team members, you remember Madison, right? Yeah, Madison published a review of the literature globally where it's the same pattern. MPs reduce ED use, hospitalization, cost, and improved access to care. Yeah, yeah. So it's a good workforce. It's growing. People are more open to getting care from MPs now. So and it's a good solution for primary care issues because people are getting older, and we got to find a way to deliver good care. And MPs seem to be a good provider to focus on.
Interestingly, you mentioned is about detection. I mean, in the process, once the orders are like registered, they have like the tools or applications that put register first or to screen before enter to the care, or in terms of continuity of care, if the one patients enter, or how the NP like follow up or providing care in terms of continuity of care, please.
So you're right. So there are various ways. So one of the biggest, not the biggest, it's a growing model of care in the US. It's called urgent care clinics. So it's a clinic that you can just show up and whoever is there takes care of you. On one hand, this is a very good model to help people have easy access. For example, the kids have an infection. Instead of calling your doctor's office and waiting forever, you go to urgent clinic, you get a test if the kid is sick, has a strep, get antibiotics or whatever. But the issue here is that every time it's a new patient, right? So there's no continuity of care. Every time MP sees a different. In many primary care clinics, MPs operate like the main provider. So MP, if you're an MP, I'm your patient. I always see you. So there are those models as well. And in some clinics, MPs are also like whoever if shows up walk-ins. So there are various ways MPs are being used, from main provider that delivers continuous care to episodic care, which every time it's a new patient. So there's and anything in between. No, you're absolutely, it's clinics are using MPs very, very differently. So. Yeah. Okay.
One more question.
Yeah.
Because of the new government, it seemed like they delete nurse
Okay.
from the professional.
Oh yeah.
So are there any effects on NP or healthcare professional?
Let me tell you, you're right, but it's changing. So let me tell you what this issue is that our lovely government decided to not give loans to nursing students to get a master's or doctoral degree. So it says you only can get a 4 years of loan, but we know that DMP or MSN is more than 4 years, right? So they removed that list. So, but now there's a lot of criticism about it. So now they open, it's called so when the government makes a change, they open the, to get public input. So now it's open, I think, till end of the March for people to give input to change it. So I think it will be changed. Of course, it will have a major impact if nurses cannot get loan. And I told you how expensive nursing education is in the U.S. Then you're not going to have MPs or DMPs because it's too expensive. So hopefully, it's going to be changed. Yeah, but you're absolutely right. There's a lot of argument, a lot of anger about it. That people need us, healthcare needs us, and now we cannot get educated. So, but it's going to be changed. Okay. Yeah.
Thinking about this issue may impact like a nursing shortage in the
It will,
future.
absolutely, because even we're training so many nurses, right? MPs, we still have many. It's a huge country, US. We have many areas. People have to drive like 40 kilometers to get to a closest clinic. That's a lot of driving. If something happens, so we need to really make it easier for people to become nurses if we really want to deliver better healthcare. So yeah, but hopefully it will change. Because there's a lot of pushback, a lot of arguments, a lot of anger among nurses that what do you mean, you know? So hopefully it will change. Okay.
Any questions from
let me see. I don't see it here. Where can I see? Oh, here. Oh, let me see. Oh, it's here. It should be here. Okay. This is okay. Here. Oh, okay. No.
no?
No, right? Yeah.
Yes.
Okay.
So
It's okay.
can
Okay. I'll ask if there are any questions on the Zoom, please you feel free to put on the chat or unmute yourself and speak up. If not, it's okay also. Don't worry about it. It's yeah. If there are questions, I'll be happy to respond. If not, thank you for being here.
Yeah, I think we have many PhD students
good.
in Zoom. So
Good. Keep up doing some good research so you do better, change the healthcare.
so do you have any question? Please feel free to ask the Professor Lusine.
Really okay. Thank you for being here.
Yeah. Good.
Experience.
It's okay.
Mm.
Me neither.
Practitioner. Just understand a little bit. So maybe I will change another question.
Please, whatever.
Yeah, please.
Why I'm here because I see the collaboration for the international study that interests me to join the speech. So, for example, if we have the more serious I concern, the question is how to do the international, I mean the collaboration or collaborative study between the countries. That means if we have we have a good plan or good research, how to say the research plan, we can consider each other's culture or not, or just do how to test the flexibility or something in other country like this.
My dissertation when I was a PhD student was focused on 8 countries. I was very fortunate because my advisor had the data from 8 countries. So that's, sometimes opportunities are what your advisor has, right? When you're a PhD student, right? Like so my dissertation title was Nurse Burnout. Imagine 2008, I was studying nurse burnout before COVID and everything else. So it was nurse burnout in 8 countries, and I think it was US, Canada, New Zealand, Japan, Russia, Armenia, Germany, and UK, 8 countries. Because I had a 55,000 nurse data. So I could analyze the data from 55,000 nurses in these countries, and I did it. So that was one opportunity for me to expand my international collaboration.
Yeah.
But the other thing is also, for example, like I told you these tools that we developed, right? People would reach out and we always collaborate. With my students, I always say, you always ask. So let's say if you're interested, let's say I've done some of these projects and you're interested in joining, right? Send an email. I always ask my students, reach out. Some people might say yes, some people might say no, and that's okay. Because that's how you slowly build your networks and teams and and you don't have to work with everybody, right? Like, for example, Apiradi and I worked together for 20 years because it works. I like working with her, she likes working with me, I learned from her, so but there are other people I don't work with, right? So it's you reach out, let's say, for example, you say, hey, Dr. So and so, I really like your project. I was wondering if we can do this project here. This tool that I showed you, these people just reached out to me. They said, hey, can I use your instrument? And I said, of course. I never say no. So it depends what you're interested in exactly. Who does similar research? Reach out. I would say most people are always open to collaborating. That has been my experience of doing this for many, many years, is that Yeah, you might get some people who never respond to your email. That's okay too. But usually people are very open. If people reach out to me for using the tool, I always say, yes, please do it, because I think collectively we can do more work together. So be proactive. Because sometimes I remember when I was a student, I was always like, oh, I don't want to bother someone. I don't want to reach out. I don't, no. It's the same thing, right? But you start small. You start small to help you. Like, look, all these things I've shown you, it's 25 years of work, right? So I didn't do this in 2 years. So start small, think about who can work with you on it, reach out and then see. You'll be surprised how many interesting collaborations are going to come out. But if you don't reach out, people don't know you want to work with them. So then it's never going to happen. So think about what you're really what is your PhD research area? It's okay.
Do introduction for myself.
It's okay.
Yeah, I'm a PhD student in Faculty of Nursing. This year is the 5th year. I do grounded theory study, empathy among the family caregiver of dementia patients. So you'll refer the dementia. I'm very interesting.
So you're going to finish it soon, right?
Yeah, maybe
Okay.
do the dissertation. Yeah.
What are you going to do after you finish your PhD?
I'm a nursing teacher in Chinese, one of Chinese university
Okay.
named the Jilin Medical University.
Okay.
Lecture.
Okay. Okay.
Yeah, maybe for next step, I develop a theory. I want to use it to do some, how to say, develop the tools or as the concept foundation.
Okay.
I'll develop the interventions.
Oh.
Use my
Okay.
theory. Maybe
And we don't do a lot of, as you see, we don't do a lot of, one of my team members slowly starting to do a lot of caregiver research because we mostly look at the formal caregiving, not the informal one. But it's, think about, like, look up who has done something that you really are interested in, and say, hey, I'm developing this tool, or do you want to give me some advice, collaborate with me? And yeah, but that's a very interesting area. So you're going to go back and be a teacher in your school. That's amazing. No. But always, I know it's hard. When I started my career, when I came to Columbia, nobody was doing MP research. So I was by myself. So I didn't know. I would send like 20, 30 emails. And every day I would check my phone. I'm like, did they respond? Did they respond? Because, because I was by myself and I was doing this work and it was hard. Yes, now a lot of people want to work with me because, but that was not the case before. I exactly would check my emails if I had a response for someone who wants to help me with a grant, because especially when you write a grant, you cannot do it by yourself, right? Like, I wrote it, but I need to show reviewers I have other people. So I'd reach out to everyone. I was new. I didn't know anybody at Columbia. So I'd send, a lot of people would not respond, which was okay. But one of the professors, I remember, and he's working with me on this project till now. I sent him an email. He was a very famous professor at Columbia. So I sent him an email and I was anxiously waiting. Is he going to respond? Is he going to respond? Because if he doesn't, I don't have people to work with.
Mhm.
And he did. He responded very nicely, asked me to go to his office. And now we are friends. And he has been with me till today. There are a lot of other professors who didn't respond. I don't remember their names anymore because it was 15 years ago. And I'm always grateful, and he knows it. And in the meetings, he comes to my meeting, and I always say, when I was new and I didn't know anybody, he just thought, oh, my ideas are good, and so do it, and don't take it personally if somebody doesn't respond to you. It's not about you, But then there's sometimes good people who reach out and say, okay, let's talk about it. But always be proactive. This is your work, Sounds good?
Yeah.
Okay. Thank you so much for all the questions, for being here. I appreciate it.
Yeah. Any
Good.
more questions?
It's okay. You don't have to feel forced.
Yeah.
I think you. Thank you for having me.
Mhm.
I'm really grateful, and thank you people on the Zoom for joining this morning. appreciated your presence, your time,
Uh-huh.
your attention. I know everybody's very busy, so I'm very, very grateful. Thank you so much.
Okay.
Okay.
So you and if someone who are interested in more lecture of Dr. Lusine, we have two more.
Yeah,
Two more
the-
lectures. Yeah.
you're gonna hear me a lot. Yes, please.
Right.
Thank
So
you so much, everyone.
Yeah. So thank you everyone from Zoom and everyone in the class and especially for Dr. Lucine. So I think everyone we get more knowledge and many inspiration for doing the future research.
No,
All right.
I get inspired by you guys and your new ideas, and then by the next generation who's going to do better work than I will do. So thank you so much, and thank you for hosting me.